I'd like to introduce our next speaker. It's Brendan Kwaziga, who is from UNICEF, here to talk about traditional vaccines.
Thanks very much. I think I have the role also to bring people back from tea and coffee. So I try and hopefully make it interesting for them to get tempted to come back. So I think it's a good transition to move from early session around costing for COVID to thinking about traditional vaccines. We're usually advised to have very clear words in the title that everyone doesn't have to look for an interpretation for. But I feel like in my title, I may have to interpret traditional vaccines for some people in the room. Or do I? Does everyone know what traditional vaccines are? Or is there anyone in the room that know what traditional vaccines are? By the raise of their hands? No. So in most of the low-income countries, which still receive Gavi support. So traditional vaccines are the non-Gavi funded vaccines. So in this session, we can use that as the operational definition, but in the subsequent slides, I will show you the specific traditional vaccines. So I've already been introduced, so I didn't have to do that session, the point of introducing myself. But just to emphasize the story I hope to tell today. So traditional vaccines are in this session, I hope to raise some awareness around the state of financing in terms of what are the key issues with regards to financing of traditional vaccines, what are the problems that are underlying the issues, and what needs to be done to ensure that we strengthen the financing of traditional vaccines. So that's my presentation outline. Now, what are traditional vaccines and why are they important? I think that's the important question for us to reflect on. So for most of us, and I think when Logan was giving a history of the immunization economics, she talked about the early work around the program itself. But the traditional vaccines basically are the foundational vaccines at the start of the immunization program. So the vaccines which we know we listed BCG, measles, OPV, and TT. So I know most of the sessions we have had and are planning to have will talk about new vaccine introductions, but they are the foundation of the vaccines we had at the start from which we are building. So if we don't get traditional vaccines right, then most of the stories we're talking about transition and sustainability may not be able to make sense because we have had almost 30 years to experiment in terms of transitioning and sustaining traditional vaccines. So what is the issue with traditional vaccines? So governments were supposed to have taken over financing of traditional vaccines around 30 years ago. So mid-90s, 1994 onwards. But we still see that some countries are not paying totally. Others are partially paying, meaning insufficient. And in most of the other countries, there's delayed payments attributed to systems issues, all which then affect the availability of vaccines on time. You know, with health, it's not just about money being available, but it's being available on time in the right quantities when it is needed. So usually that's how you have to reflect around availability for funding in vaccines. Now, as I mentioned at the beginning, if we are not able to figure out traditional vaccines, basically if we don't understand how to finance them sustainably, then we face a big challenge as we think through how to sustainably finance new and underutilized vaccines. Now, what is the status of financing for traditional vaccines? So we did a quick survey at the start of the country focused on the fragile and conflict countries and basically confirmed some of the issues I've just talked to. You can see in the last column, almost all the countries are relying on donors to pay for the vaccines. And even those which are relying on government, the allocation is insufficient. So donors still have to contribute in this list of countries. So 4 main issues there. So still a big reliance on donors, where government is paying, it's not sufficient. And then you have an issue of systems issues in terms of PFM, late release of funds, so predictability and timeliness. And the fourth issue around prioritization. So, of course, we are in the context of a pandemic, but this sample of countries also faces another challenge around fragility in terms of wars. So usually the prioritization is within the country in terms of the resources they have to distribute to other sectors, but also what gets the vaccines eventually. So these are challenging contexts. But now also there's an interesting dimension of prioritization, because as countries introduce new vaccines, the resources are not growing proportionally to match the new vaccine introduction. So there's potentially some contestation in terms of prioritization with new vaccines, and I think I'll show that also with data in subsequent slides. Now, to illustrate with a country example, and I'll talk to this slightly crowded slide. So the first, trends on the other side show variability across years. And of course, we are in a slightly just post-COVID period. So it's not very good to show slides post-COVID, but show trends post-COVID, but we see that if you focus on the dotted line, that's the traditional vaccine expenditure. Of course, it is the least across the countries, and it's been more so stagnant for most of the countries in terms of trend. Now, if you now look within countries, in terms of variability within country, I don't have a point on this, but the least expenditure component is still traditional vaccines, again, with minimal variability, but also still the lowest expenditure component. So on this slide, just emphasize that traditional vaccines ideally are the cheapest vaccines within the countries, and hence should be the most affordable for the countries to manage, because it should be easy to manage. But as I told you, we're still suffering those challenges around countries being able to afford them. Now, I talked the issue around prioritization in terms of potential crowding in or crowding out. So the design of co-financing as a model is meant to crowd in expenditure, so governments are encouraged to contribute so that the pot becomes bigger. But because of dealing with constrained resources, you may end up in a scenario where there could be crowding out, meaning the money available may reduce in terms of what they can allocate traditional vaccines. And although the data is not too strong now, from the samples we have looked at around 6 countries, and thanks to my colleague Naomi, who's doing some work in West Africa, we show that there's some potential crowding out in terms of the relationship between what governments are spending on traditional vaccines versus co-financing. So meaning the focus on co-financing by countries is taking away some resources. Some use the simple English, taking away some resources from traditional vaccines, and hence threatening sustainability. Yet, as I was saying, traditional vaccines are our foundation on which we are supposed to build the EPI system. So having realized the challenges with the system, so what is the problem? So this slide is crowded and invisible, so that I can talk to it, so that the focus can be on me. So the root causes is mainly the economic issues. So the root causes, as we know, post-COVID, but also post the other previous financial crises, the health budgets have been strained. So there's been limitations in terms of the growth of the health budgets, which then limits allocation to health. But then the underlying causes are some of the issues for which, as the health sector, we have some levels of control. So in terms of how much gets allocated to immunization, in terms of how we're optimizing our vaccine portfolios, in terms of the new vaccines we're introducing, but also the capacities for forecasting, quantification, but also programming itself in terms of how we do our service delivery. I think from the last session, we had some experiences on how the design of the costing, the design of the delivery platforms may influence some of the costing, but also, of course, can influence the way you finance. So there are some underlying issues which may then affect what is available, when it is available, and hence threaten the financing of vaccines. These that I'm calling immediate are the issues we have seen. So money is not there. When it's there, it's not enough. When it's enough, it's coming late. So all those are what we are seeing as threats to sustainability of traditional vaccines. So now, so what? Because what if we don't pay for traditional vaccines? What will happen? So the cost of inaction has implications both at system level, but also at household level. So what's the cost of inaction? So within the system, I was happy to see that workforce was a key concern around the cost for COVID. So when vaccines are not available or when they delay, you're basically misusing your workforce. You have them there, they are ready to provide the services, but they are not able to be used. Potential outbreaks, if there's not sufficient coverage. There's an issue of system to treat the patients in case there are infections, but also there's an issue of building public trust on vaccines when they keep coming to access and they can't find any. Now, one of the intangible system costs that I didn't include, but I would love to talk to, and I keep emphasizing, is that I doubt that you will convince anyone that will be able to sustainably finance new and underutilized vaccines if we can't demonstrate it with traditional vaccines. So to me, I also see that as a very important and serious system cost. Unfortunately, it's not very easy to quantify in a monetary terms, but I know for most of us here who are policymakers, you understand it. It's a trust component in terms of policymakers. So I think it's also an important cost. The other are the household costs. So there's a cost due to repeatedly visiting the facility. So if I want to get vaccinations and I keep going and I can't find, of course, I incur a cost, but also it affects my trust. The system is not giving me what I need. So there's also costs related, of course, to treatment due to disability. There's costs related to health seeking when you fall ill. So the cost of inaction is immense. And of course, will vary across countries. Again, to try and link with the previous session, I know we said global estimates may not be very exciting to look at. And at times within a country, you may want to do your own modeling to just show the cost of inaction. But I think for some of these, as we advocate for strengthening of systems for financing of vaccines, I think this is some good illustration in terms of how we can demonstrate in our countries. Now that we know what will happen if we don't finance our vaccines right sustainably, what should we do? So in terms of a theory of change, at least in planning form, and I know this is a very rich room in terms of what to contribute, we know that if we are able to, have government to prioritize better in terms of allocation to health and primary care, and also we strengthen the capacities around planning, budgeting, and also strengthen PFM systems, then it should be able to translate into better prioritization in terms of allocation to vaccine procurement, capacities for procurement planning, and demonstrate more value for money, which can then solve our problems by ensuring that our resource allocation is more predictable, resources are more adequate in terms of the allocation, but also they are used more efficiently, and then that will translate into more money being available to sustainably finance vaccines. So that is our working theory of change. I know my thing as present, so I hope the next slides are able to move. But in this theory of change, and it's unfortunate that the lower part is covering one of the underlying blocks. The foundation, okay, I can see it's now moving, perfect. So I'd already talked to what we need to fix and what you can achieve after fixing it. But there's a big foundation there which is currently being covered by the panel. The importance of a supportive environment, or what you call political economy, because all this happens in the context of a political economy within a country. Now, why is this important? We can say all these fancy things and have all these technical solutions and be able to convince technically, but resource allocation is a contestation. It happens within the politics of a country, the politics of a state. So you need to be able to know the different actors, the power, the incentives, the interest groups, ideas, and institutions. And earlier on, when I was talking about the potential link between co-financing and traditional vaccines, I already talked about an issue of incentives, but even within a country here where we know that governments need to prioritize, you need to know the different actors and how they can influence the allocation decisions. Then important and emphasis that politics affects choices. So you need to know who the big decision makers are and the different kinds of politics within the country. In the past years, UNICEF has done some work on the political economy, focusing on traditional vaccines, with a starting simple basis that these things are very cheap. Why aren't governments paying for them? Like, because it's really common sense. It's like for most of us, we know the cheapest things should be easily paid for. If people are not paying for them, then there could be something that is really causing that. So some of the outcomes from that analysis was that government budgets need to be the foundation, and we need to understand who are the key decision makers, both formal and informal, around the government budget. Then important emphasis around the relationship between ministries of health and ministries of finance, and also the composition and the role of stakeholders within the country, and the donor perspective. As we saw earlier, there's a lot of donors still financing traditional vaccines, even when we know that's government priority. But of course, we know that countries are undergoing different kinds of strains and constraints. So the donors supporting this area, we need to also understand their perspectives and what motivates them to still support traditional vaccines. Now, moving forward, I'm supposed to move my last slide. Next slide, please. So in trying to bring all this together in terms of what we can do, there's some potential action both at global or regional level, basically supranational, above the countries, and also within the countries. So above the countries, in terms of what we can do at the regional and the global level, I think it is important that we awaken our interest and our focus, because I know new is always fancy, but traditional is the foundation. So we need to understand and highlight this issue again. Probably the time between 1994, 93, and now 30 years can make us forget the importance of having a strong foundation. So we need to do some more work in terms of both analytics, but also what I'm doing now, sharing, to highlight the issues around financing for traditional vaccines. We need to demonstrate cost in action, both in country, but also I think may make sense at the regional and global level, but also explore some of the opportunities within existing policies by the donors to have a more organized way of support if they have to support. So in most instances, when governments don't play their role, donors usually come in to save the situation, meaning even when they are doing something good by funding them, some often coming late, and hence not even sustaining the system itself. So how can we be less ad hoc in terms of the donors by having more structured policies? I think to appreciate Gavi, because they have something around fragile and conflict countries and how they can support them. But I know, and we have colleagues from the World Bank here, even the IFIs have been doing some work for financing traditional vaccines. So they need to have a better organized way they engage with the governments, where they inbuild sustainability in terms of the discussion. An important bit as I said, the government budgets are the foundation, it's the basis. So having better visibility, and I know colleagues are working on having a budget databases for immunization so that we can keep a view of what is happening within the budgets and what's happening specifically around both traditional and new vaccines. So having a wholesome view around vaccine financing. Lastly, I know the team behind is very impatient. So for countries, there's so much action, country context matters. So there's need to have a bit of differentiated action. I think the first recommendation is around, especially we have seen there's delays in funding, there's challenges with predictability. So there's a lot of work to do, bottleneck analysis around the PFM systems so that you can have more informed action around the countries. There's also a need to use the long-term planning opportunities. So my colleague Ronki talked about the national immunization strategies, but I also know that there are levers, for instance, through the full portfolio planning to better plan on how you can optimize your vaccine portfolio so that you don't strain the country, but also make sure that population benefits from all the available technologies. The other bit, which is I think very important and building from the political economy discussion I was having earlier, is how you structure your advocacy. Again, countries are different, and the way you structure your engagement is different. So think of the platforms that work for your country. Important that in the fragile and conflict countries and probably countries with economic strain, you have a less ad hoc approach to financing. And lastly, not an advert, but UNICEF has a vaccine independence initiative, which usually tries to smoothen delays from government funding. So for countries which are not using the VII, that's also an opportunity to try and smoothen payments for vaccines so that they don't delay and people are able to access vaccines on time. I've been able to deliver on at least bring you back in the room. And hopefully you're able to also follow the presentation. Thank you.
Thank you. Right, so next we have Emmanuel Aitha, who is from Send Ghana, here to talk about tracking budgets.
Thank you. Good morning, ladies and gentlemen. My organization is a purely policy, research, and advocacy. So all that I'm coming to talk about is really not looking at so much of academic, but pointing to policymakers. Because for us, we believe that that is what matters. And we are going to basically look at issues of budget credibility, but that we are just looking at deviations as far as issues of budgetary allocations and budget disbursement are concerned. It is critical because, as the earlier presenter indicated, if you clearly look at what he said, it's purely an issue of budget. Because without budgeting for immunization, you can't really do much as far as what all of us are envisaging is concerned. I'll just keep this. So Ghana has been touted as one of the good success stories as far as, permit me to move here because it appears it's better this side. Ghana seems to be one of the good countries to cite if you are looking at issues of immunization coverage, at least in the West African sub-region. In terms of using Penta-3 as proxy, Ghana's coverage is around 99%. And if you look at the map, this is my country, Ghana. And if you look at what is here, the global statistics, it tells us that yes, if you are using these, then we are not doing that bad. However, the very important point is that there are some disparities or variations as far as coverage is concerned. Although we are hitting as much as 99.4 coverage, it's not that good everywhere in Ghana. That is the point for this slide. if you look at, this is the map of Ghana, and actually this is the old administrative map, which has 10 regions. But now Ghana, we have 16 regions. The politicians just decided to divide some of the regions, sometimes just for their own interests. But what we are concerned is about the fact that out of 260 or so districts, coverage of for 46 districts is way below the national average and the global average. So if you look at these 46 districts, they are doing between 50 and 85%. Whereas our national average, as I indicated, so it's where we are about 99, and the global average is about 80. We shouldn't think that because we just have about 46 out of the 260, we shouldn't be concerned about it. Of much concern is also the fact that even in certain urban areas, Accra, Cape Coast, and all the big urban areas, coverage is an issue. And so what we sought then to do is to look at what the issues are. And anecdotal evidence points to issues of budget. And the fact is that we do not seem to have evidence as far as district level budgetary allocations are concerned. If you look into the literature, there is dearth of literature on local level budgetary allocations, disbursement, and budget execution. When you pick most of the information out there, they are purely at the national level. But we thought that it's important to look at the local level budget execution, and that is where our research focused on. We tried to look also beyond just looking at execution. We want to look at what then will be the effect on immunization service delivery. We focused on 5 districts. Why might wonder if you have about 300, so 260, why just 5 districts? Because we had already started some work there, and we thought that it would be proper just to concentrate there, considering also the short time. We just had about 6 months. Also, it is because these districts are also part of the districts that are not doing so well. So we wanted to find out what the issues are. Because we are looking at district level, we interviewed district level personnel, i.e. district coordinating directors. They are the senior district administrators. If you take off the political appointees like the district chief executive. We also interviewed budget officers and planning officers because they also hold the purse at the district level in terms of purely administrating. And then we interviewed what is called disease control officers. When it comes to immunization service delivery at the district level, it is the district control officer who is in charge. And lastly, the district health directors. We interviewed them. We have what is called district health management team, and comprises of some of these people, especially the district health director and then the disease control officer. Quick about the findings. Clearly, what we see is that both at the national level and at the district level, immunization seems to be prioritized because immunization is actually factored in what is called the medium-term development framework or plan for the country, Ghana as a whole. If you look at the district-specific ones too, districts have prioritized immunization. You see immunization in the district medium health development plan. And there's a health sector-specific one. So what you see here is the health sector-specific immunization. You talk to the district officers and they say that because immunization is very critical, at least within the first 1,000 years of every child's life. And for that matter, that is why they have factored in. We sought to find out the sources of funding for immunization at the district level. And largely they pointed to development partners and non-governmental organizations at the district level. And we sought to find out what they use the funding for. And it's purely to support outreach services for for cold chain, you know, when you are going outreach, they have some small cold chain stuff that they put the vaccines in. Aside the cold chain equipment, motorbikes to support transportation for outreach services and also for supervision. Basically, that is what they get it from. But aside looking at development partners and NGOs, in Ghana, we have what is called the District Assembly Common Fund. In fact, that is the main source of funding for all district activities. And we got to know that 0.2% of the District Assembly Common Fund actually goes into support immunization. And so that is what, if we are looking at really what comes to the district, aside from what development partners and NGOs contribute, that is the percentage. And that depends on the district. So some districts will get so much, others will get so little, depending on the revenue generation. And basically, these pictures here, this one is showing some of the cold chain equipment we cited, and these are people going on immunization outreach. These are hard to reach areas that they have to use canoes and boats. So the money that the district actually gets, as far as their budget is concerned, these are some of the things that they use it for. Because it's about immunization financing, which sits within the Ministry of Health, we sought to find out what proportion of the Ministry of Health budget is to the national budget. Almost 20 or so years down the line, where Ghana and other African governments signed to what is called the popular Abuja Declaration for countries to actually commit to 15% of their national budget to health. Our estimate shows that Ghana so far has been doing around 8%, not even up to 9%. That tells you that to some extent, it has also effect on how much we get for immunization. And so that is what this slide is trying to tell us. And then this is looking purely so at how well we are doing as far as immunization is concerned. It's actually less than 2% if you are looking at the country's budget allocation to immunization. This is at the national level. Let's see what the districts that we looked at we looked at 5 districts, as I indicated. And clearly, what the results show is that if you are looking at the national, where I indicated that in terms of budget is around 8.4, district budget allocation for health is less than the national level. So districts are even doing way less than the Abuja Declaration, compared to the national. That should also tell us that then in terms of immunization, you are likely to also have districts not doing better. However, what you see is that if you look at the national picture, where immunization is having just about 1.7%. If you look at the districts immunization prioritized in terms of budgeting is a little higher than the national level. We cannot speak for all districts, as we are just looking at 5 districts. Even for the 5 districts, we didn't have data on all the 5. We got data on 3. So we got data for Esiojaman, which is in the eastern region of Ghana. Tatale is in the northern region. Kasina Nankana is also in the northern region of Ghana. And clearly what we see is that except for 2018, where we had 7% allocation to immunization 7% to health for Esiojaman. Roughly all of them have been doing way less than that. But the good point here is that in terms of budget, if you look at sub-national level, we are doing better in terms of immunization allocation than the national level. What we have here basically is also looking at district allocations to immunization and disbursement. As I said, we are looking at budget execution. So it's not just about allocation. You can't allocate, but you not disburse. And if you're not disbursing, that means that there's no money to spend on immunization. For 3 out of the 5 districts, we had data. And so for this district, Estrojaman, yes, they allocated some money for immunization, but when it got to disbursement, nothing was disbursed. And this wasn't just for one particular year. For all the years that we are looking at, no disbursement. So the point is, why would you allocate if you are not disbursing? Because if you allocate, it actually helps in planning. And if we plan for such outreaches and there's no money, then it would affect immunization service delivery. The same with Tatale, they disbursed, there was allocation but no disbursement. So percentage was obviously 0. Surprisingly, Kasina Nankana did not actually provide any information of health budget. In fact, we asked them and they said that in all the years, they were not actually given any money budget for health. But that goes to talk about what the earlier presenter said about relationship between the Ministry of Finance and Ministry of Health. At the district level, it's not about Ministry of Finance and Ministry of Health. It's about the district health directorate and then the district coordinating director or the district chief executive and the like. And later in the recommendation, you see, I mean, that is also what plays out, at least at the Kasina Nankana level. However, the district actually made provision for immunization because they realized that it is something that is critical. If you've been to up north, unlike in the south, sometimes even accessibility to health centers and the like are a key concern. And so that is what we see here, that they even overspent on the budget that they actually, that's for Kasina Nankana district, that was allocated, which is also an execution issue. The main point had to do with challenges with adequacy and timeliness of delivery. Even where budget has been allocated, even where budget is being disbursed, it doesn't come in timely. A point in case is the District Assembly Common Fund. As I indicated, that is the main source of funding at the district level. Unfortunately, although the name says District Assembly Common Fund, it's supposed to be common, but in actual sense, it is not common. All districts that we spoke to said that, especially for the time that we went there, it's supposed to become every quarter. 2 quarters they hadn't received. So that meant that for January through to June, there was no money. It only went to them in October. And so the point is that how common is it common fund? If releasing, it's a big issue. And indeed, other research suggests that for 5 years, some districts, 5 years, they said they actually have not even received any of such allocation. We sought to find out general about how people are satisfied or otherwise, as far as immunization service delivery is concerned. And the picture is clear. If you look at what is here, this is about satisfaction level and not being satisfied. A greater proportion are generally not satisfied. If you look at all the districts, it's only when you come to utilization. Obviously, once there's disbursement, everybody will be satisfied with utilization. But the picture here tells us that district level officials are not satisfied with immunization budget execution. And it's purely because of issue of timeliness of delivery and allocation. This will probably be the last, in terms of the last but one, effects of late delivery of financing, effect of poor budget execution on immunization, as the fact that these are outreach services, and we have a lot of outreach services because of the rural nature of communities. So once you do not deliver budget as expected, that means that it affects immunization service during outreach delivery in terms of all the key things that I spoke about earlier. And what happens is that is the life of especially children, because immunization broadly is not just about children, but it's children's life that are affected so much. A quick note on recommendations and I'll be done. As I indicated earlier, we have immunization clearly stated in both the national and district medium-term development plans. But it's important to have a specific budget line. If you look at our budgets, both at the national and the district level, I'm emphasizing the district level because this study is at the district level. But even at the national level, we don't have a specific budget line on immunization. So it's subsumed under the bigger health budget. And that means that you leave it at the whims and caprices of the one taking the decision, purely the health minister or the main person in charge of the health budget. But if we have a situation where immunization is clearly specified, there's a clear budget line, then nobody can touch the money for any other purpose. And so that is one clear recommendation, that budget lines should come with specific lines for immunization. And once that is done, it is going to be really followed and also help for those of us who are into monitoring to monitor closely to see how that is done. The last, in the interest of time, I want to talk about COVID-19 health levy quickly, because this is a levy that government actually instituted during COVID time to raise revenue. Now COVID is no longer there, but the revenue is still being collected. So what we are saying is that channel that money into public health emergency fund and obviously use that to fund immunization and other things. Thank you very much.
Right, okay, so we have one last presentation in this session today, and that presentation will be from Grace Chi from JSI.
Hi, everyone. My name is Grace Chi. I'm the project director for USAID-funded Momentum Routine Immunization Transformation and Equity Project. Thank you for the opportunity today to present on two pieces of our work. I just want to give a little bit of background to our project. We are a 5-year project that was awarded in July of 2020. And our vision is a world in which all people eligible for immunization, but particularly the underserved, marginalized, and vulnerable populations, are routinely reached with high-quality vaccination services, and that they use them to protect themselves against vaccine-preventable diseases. As in our name, we were designed to focus on improving the equity of immunization. I want to just some project information here. We're currently working in 18 countries. In all 18 countries, we're supporting COVID-19 vaccination, and that's wrapping up in a few countries in the last couple months. In 5 countries, we're supporting routine immunization, and those are DRC, Mozambique, Kenya, Nigeria, and India. And over the next couple months, we're actually adding 2 additional countries, Benin and Cote d'Ivoire. This slide provides an overview of the project approaches. As you can see, at the center is the health provider and the person or caregiver receiving services. We're really focused on that interaction and aiming to improve access, trust, and providing reliable services. And we do that through interventions both on the individual and community side, as well as on the health system side. So along the top, you can see that we're aiming to reduce rates of 0 dose and under vaccination. But on the health system side, you'll see that along all levels of the health system, the facility, the district, as well as the national level, we're really aiming to improve planning and increase resources at all levels of the health system. Key components of having sufficient resources is around operational costs. So why focus on operational costs? Well, traditionally, financing for immunization has focused on big ticket items, primarily vaccines. Gavi's focus on co-financing is only for the cost of vaccines. We know that non-vaccine, non-labor costs represent only about 10 or 20% of immunization costs, but they're really critical for ensuring last mile delivery, especially if we want to reach zero-dose and under-immunized children. In many countries, operational costs are funded from subnational budgets. So national immunization programs are not able to see how much is spent or whether or not that's sufficient from one district to another. And as I said, operational costs are really critical for reaching zero-dose and under-immunized kids. So what are some operational costs? So for example, they include the cost for fuel for last mile vaccine transport. That might be a health provider, a health worker at a health facility going somewhere to retrieve vaccines. They include the cost of supervision, which is really critical for ensuring high quality services, cost of fuel for cold chain to ensure the quality of vaccines and their effectiveness, as well as cost for outreach services. Services can be provided where it's convenient to reach our target populations, as well as cost for printing and stationery, social mobilization, and health promotion. So recognizing the importance of operational costs, MRIGHT has designed two activities that focus on this. The first is to develop and test a methodology for monitoring some national immunization expenditures. And I'll tell you more about each of these. And the second is to build the capacity of some national EPI managers and health officers to advocate for increased funding for immunization. So on the methodology for monitoring some national immunization expenditures, as I said, NIPs don't usually have a lot of visibility on operational costs at district level, and districts with low coverage may not have enough resources to conduct the activities that are needed to really improve coverage to reach zero-dose and under-immunized kids. In DRC, we're developing a method for routinely monitoring some national government expenditures for operational costs using data from existing financial reporting systems. So the goal here is not to do a one-off costing, but to find a one-off study, but to find a way to monitor expenditures that can be applied so that we can compare expenditures from district to district as well as from year to year. We'll be first applying this method in 2 districts, and we'll then validate the findings with district officials and the National Immunization Program to understand the findings and their implications. And the goal is to have routine expenditure data that can inform resource mobilization discussions at national and subnational levels. The way we'll be doing this is we'll be interviewing district accountants and health facility staff to identify key data sources, activities, and also to understand the public expenditure reporting system and financial reporting practices. We'll collect information on the activities through the state accounting system and develop an Excel tool for data capture and analysis. Our analysis will entail allocation of shared costs and also look at what existing coding is used and how that could be standardized or adjusted so that operational costs could be tracked in the future. As I said, we're aiming for a methodology that can be embedded in immunization management units, and we'll be building their capacity to data. Our second activity focuses on advocacy at subnational level. We often find that local health officials are not able to get support from local finance officers and district executives to allocate more resources in order to reach zero-dose and under-immunized kids. So in Nigeria, we're working to understand where immunization fits within the health financing landscape and how operational costs are included in local health budgets. Then we'll be providing technical support, coaching, and peer-to-peer learning to help EPI officers and health officers at the LGA level to use financial and programmatic data to advocate for increased funding. The goal will be to increase resources for immunization at LGA level. So we'll begin by conducting a rapid health financing assessment at the LGA level, identifying the sources of funding and how it's used, as well as understanding the budgeting process. We'll hold co-creation workshops to bring together government officials, community leaders, and private sector representatives to validate findings and also to identify priority needs around capacity building as well as advocacy opportunities. Likely, our capacity building efforts will focus on identifying financial, programmatic, and epidemiological data that can be presented during planning and budgeting processes, as well as providing information so that health officials can understand the health budget, the budget cycle, and the planning process. And this work will contribute to a toolkit for EPI officers and local health officers to support engagement with LGA executives and finance officers. So for both these activities, we expect initial findings in about September. After that, we'll be more focused on institutionalizing these approaches, both in DRC and Nigeria, and potentially considering application in other countries. So we would love to collaborate with other partners, especially in this crowd, anyone who might be interested in working together to monitor operational costs at subnational level. Please feel free to drop me a line and let's connect offline to see whether there are opportunities to collaborate. Thank you very much.
Okay, so we've only got time for 2 very quick questions because I don't want to keep you all from your lunch. So can I welcome our speakers back to sit? Brendan, come join. So 2 quick questions.
Thank you. Thank you for the great presentations. I'm Raymond Houtebessi from the WHO in Geneva, Immunization Department. I had a question to Emmanuel on your study in Ghana. I was very interested in knowing your thoughts on maybe a kind of a threshold for these allocations of budgets in the 5 districts you are looking at. In particular, also looking perhaps at the other regions. Have you also looked at the kind of successful districts where they had good coverage, but also at their budget execution and allocation? And maybe from there you could maybe think of a kind of a threshold for other, the less performing districts, and you learn the lesson from them. And not sure that is part of your study, but really great presentation. And overall, I think that these kind of studies should be more integrated and linked with the previous sessions we had earlier on costing, because I have the impression we kind of work in silos on these, while eventually this all needs to serve either operational or strategic decisions at the country level. But thanks again for your great presentations.
Thank you. Yes, in fact, we didn't look at the successful district. I indicated it's because we just had some 6 months to do this. And for that matter, it was more convenient to work in the district that we're working in. If I'm working in 10, and then we look at the difficult, the challenging district. But these are some of the next steps that we are looking into, because it's important to compare with what is happening in the districts that are doing well, and then these ones that are seemingly not doing well. So next steps, we'll look at those ones as well. Yes, in terms of trying also to relate it to costs, I think that is another thing that we can try to look at going forward, because it would be nice to look at the distribution cost or delivery cost as against the budget estimates as we are looking at. Thank you.
Great presentations, both of them. And I think we've hit a critical point here. For example, we just did a retrospective study on typhoid, on the new TCV, typhoid conjugate vaccine. And we've got a retrospective costing, and now we're going to tell the government, we're supposed to tell the government how much it would cost for them to do this themselves. Now, typhoid conjugate vaccine has been around for years, but very low uptake. Should we be talking to the districts and telling them how much it would cost? Or should we be talking to the national government and doing a national plan and a national costing like we've done before? What do you think?
sorry, from where I sit and considering the kind of work we do, where we engage both the grassroots and the grass tops, I mean, the local level and the national level, I believe it's important to talk to both. Why that is, if you are looking at money supporting coming from national government, like the District Assembly Common Fund, which comes from the national, they just make the allocations to the district. So I would think that yes, because if you really want policy actors to act, it has to be from the national level. If you understand Ghana's system very well, as far as our decentralization is concerned. However, to the extent that the medium-term development plan and also districts are enjoined also to submit their budgets to the national level, it's important that we engage them also at that level. You know, in our result, it showed clearly that we do also have some, I mean, NGOs largely and some development partners directly will support certain districts. And so if we have such discussions and engagement with them, and it happens that an NGO would really want to support the district, they can also clearly actually show that to them. So I would look at both the national and then the district level. Thank you.
Thanks. So I just want to let the man here from Last Mile Health ask a question, and then over to Brendan. And then we also have Grace on the line who also would like to comment.
So my question goes to Brennan around the traditional vaccine. I think your presentation was very insightful. Thank you for that and your well-planned actions. So my question goes back to the planned actions, especially a component that had to do with advocacy and how are we engaging government, especially around co-financing. I would like to hear your thoughts on where are we, because I always hear that as technicians, we continue to talk about advocacy, continue to engage government, how we're going to engage government decision makers around supporting some of these interventions. How should we put ourselves around the tables? How are we trying to make sure that we are the decision maker? So I would like to hear your thoughts. Should we be the decision makers? Because if we're talking about co-financing, health economists should be in the finance ministries. How are we positioning ourselves to be at the parliament? How are we positioning ourselves to be at finance ministries? How are we positioning ourselves to be at key areas that we make the decisions rather than always advocating? Because if we continue to advocate, we place ourselves in the less advantageous position where it depends on the decision maker own perspective about priorities rather than our perspective about priorities. So I'd just like to hear your thoughts around that. Thank you.
Thanks very much.
Over to Brendan and then over to Grace.
Thanks very much. I'll respond to the question around advocacy and touch a bit on the question around TCV. So on the advocacy, I think my framing was around understanding the specific politics within your country. So you can't do away with advocacy because as especially the people in the room, most of us are technical technocrats because they are political technocrats. So most times we're able to produce the evidence, we know what needs to be done, but we are not in the positions of power to do it. So so for instance, if we are able to move yourself from the current technical position and you make yourself a member of the legislature, because that's where resource allocation is done in the democratic areas, that's change of position. But otherwise, as long as you're not the legislator, then you have to advocate the legislator. So it's understanding the politics and the setting. Now, your question kind of evokes some demons in me. I'm using demons in the right way, because different countries have different centers of power. I think in one of the very good reports I was reading from Naomi, for Chad, the president made a declaration on what should be given to vaccines, and it was done. For Uganda, I remember we had around 2018-19, we had an interaction with a parliamentary committee on health. They used to have a subcommittee on immunization, and the financing for traditional vaccines was more than doubled. So if you know the centers of power and what can be done at those centers of power, then play your role right and be the advocate. So advocacy is not a language of the weak. It's what we can provide to those who have power to make the decisions. So just to take the opportunity also to talk to the TCV question, I think just to add to what my colleague talked about, understanding the decision making, the levels of autonomy within the country. So for the typical decentralized countries, especially within the region here, the functional split means that, for instance, if it is a discussion around vaccine procurement, it's a national function. And of course, I was passionate about that because I was mentioning around how countries can optimize the portfolio so that they don't buy the new toys and lose the old ones. You know, kids, usually when you buy a new one, you throw away the old one. So the discussions around optimization definitely target the national level. But we know that the delivery functions right now in most of the countries are subnational. Now, if we anticipate and expect that there will be substantial costs of delivery, then we need to engage the subnational, not just to show them the cost, but also to understand how some of those costs may be consumed within the existing structures. I think that's what I can talk to.